Hello, everyone. So we are back for the third session, and I'm joined by Heide, who you've seen before. My name is Tanja. I'm a member of the German Hypopara network.
So my name is Heide Sigelko. I work in Germany. I thank Erik for presenting me in the session before, and my task is to present you Erik Fink Eriksen. He's professor at the University of Oslo. He is one of the experts in the calcium and bone field. On Facebook for researchers, that's ResearchGate, his RGG score is incredibly at 48, and the age index at 86, who know what this is. And I'm really thankful for the last publication where he investigated the effect of T3 on quality of life in patients with hypothyroidism. However, his most cited publication is the one in the New England Journal on the effect of PTH 1 to 34 on osteoporosis. So he's one of the experts talking to us about hormonal treatment of hypoparathyroidism. And before he starts, Erik, I give back to Tanja to present the other presenters.
Yeah. So afterwards, we will hear from 4 patients. We'll have Ray Finlay from the UK, who uses a pen, and then Barbara from Germany, who also uses a pen, but with a different type of medication. And afterwards, you will see Natalie again, the president of Hypoparathyroidism France. She uses a pump. And then she's joined by Helen, who you've also seen before, from the Hypopara organization in Norway. And she's also on a pump. Erik.
Okay, thank you, Erik. Now we are looking forward to your talk.
Thank you very much. Yes, it gives me great pleasure to give this talk on the newer modalities in the treatment of hypoparathyroidism, namely hormone replacement therapy, and try to give an overview of where we are with these modalities. These are my disclosures. So you already went through the conventional treatment that's outlined here, based on calcium, vitamin D supplementation, where you need to be supplemented with sufficient amounts of both D3 and active vitamin D, as outlined previously, magnesium supplementation, and thiazides. I'll deal with the last point, PTH, and I'll deal with the results so far obtained with subcutaneous injections and infusions via insulin pumps. So already outlined also that, of course, what's lacking in hypopara is the hormone PTH, parathyroid hormone 1 to 84, produced by the 4 parathyroid glands as shown here. And it has important aspects by liberating calcium from bone, affecting renal excretion of calcium, and affecting gut absorption of calcium. So you have 2 different PTH injections. You can choose between PTH 1 to 84 or PTH 1 to 34. And the hope by developing these was compared to conventional therapy, that it would get more stable and better increases in serum calcium with these drugs, reduce serum phosphate, reduce urinary calcium, and reduce the need for active vitamin D and calcium supplementation. And as we'll see in the following, that has largely been achieved. There are issues with these treatments, and the primary one is that they both have a short half-life in circulation. PTH 1 to 34 has been developed to have a very short half-life because that's very important for the stimulation of bone formation that we want to achieve with this drug. PTH 1 to 84 has a longer half-life. And there has also been discussions on whether there are aspects of PTH 1 to 84 that are related to possible effects of the C-terminal fragment, which is not present in PTH 1 to 34. And then, of course, it is important to also show with these modalities that you actually have an effect not only on the calcium phosphate regulation in the patient, but also effects on quality of life. So just to highlight Pth 1 to 34 has a very short half-life of 3 hours. That's very important for its stimulation of bone formation, which was the main underlying reason for developing this drug. And it is more effective in the treatment of osteoporosis as an osteoanabolic agent compared to 1 to 84. 1 to 84 was for a short while also used for treatment of osteoporosis, but it was associated with a much higher degree of hypercalcemia than seen with 1 to 34, and ultimately was given up and then repurposed as a treatment of hypoparathyroidism, because it has a more prolonged effect on calcium metabolism. As you see here, it stays in the circulation up to 12 hours, not the whole 24 hours that would be desirable, but still a better pharmacokinetic profile than Pth 1 to 34. And I think that is also highlighted in the clinical results, and those of us who have tried both of these drugs certainly see that 1 to 84 is a better agent in hypoparathyroidism. Here you have the pharmacokinetic profiles of PTH with 50 micrograms injection, one injection of 50 micrograms of 1 to 84 net par, and 100 micrograms is seen here. And you see that you get a profile, a PTH profile that tapers towards zero or baseline levels around 12 hours. So it stays longer in the circulation, but still it's not ideal. You would like a continuous detectable level for 24 hours, of course. And I think this slide highlights, and I know the previous speaker, the first speaker, was kind of critical to this, but to me this is very important. Here you see urinary calcium with calcitriol, which we use in a conventional therapy. It goes up after a dose, which we don't like because it increases the risk of nephrocalcinosis and renal stones. The opposite is seen with 1 to 84, where you got a decrease and then a gradual increase again towards baseline as the effect of the drug tapers off. So the first major study conducted in hypoparathyroidism with Pth 1 to 84 was a REPLACE study that was the basis of the FDA and EMA approval of the drug for the treatment of hyperparathyroidism. And what this study showed was that after 24 weeks of treatment, you were able to reduce calcium, active vitamin D and calcium, keeping a normal serum calcium, and it was 53% reduction in active vitamin D and calcium with a normal calcium by 53% in the 1 to 84 group, and only 2% in the placebo group were able to discontinue more than 50% of the active vitamin D and calcium. And total discontinuation, no calcium or vitamin D at all, was obtained in 43% of patients versus 5% in placebo. And here you see the calcium phosphate product that you already have seen discussed in several talks, where you see that it goes significantly down and stays down over time, over 24 weeks, with 1 to 84 compared to placebo, which are the open symbols up top. So this REPLACE study was then followed by a more long-term study where the companies in a smaller group of patients that continued from the REPLACE and another study called the RELAY study. In the RACE study, 49 patients in total, and they were again adjusted with a titration of Pth 1 to 84 to achieve normal calcium and phosphate levels by a stepwise procedure. And here you see the main composite endpoint, which was that you wanted to achieve an over 50% reduction of all calcium, plus over 50% reduction of all calcitriol, and then also maintain a normal albumin-corrected calcium. And you see that over 6 years here, you are able to achieve that in around, initially around 50% and gradually up to 65 to 70% of patients, where it stays stable for 6 years. So quite a substantial effect on these key endpoints. And when you look at the calcium dose and calcitriol dose, you see here on this slide, again, up to 72 months, 6 years, that you kept the calcitriol dose reduced by 70% and the calcium dose reduced by 40 to 50% over that period of time. And also urinary calcium stayed reduced and actually showed, which is difficult to explain, and I don't think it has been explained appropriately yet, you actually saw a gradual further decrease in urinary calcium over time with treatment with PTH 1 to 84. And the calcium phosphate product stayed down from around 43 to 35 over time also. So no sign of kind of refractory effects of the drug over time. I want to highlight that the effects of PTH on bone are refractory. The stimulation of bone formation that was alluded to in the first talk goes away over time. Actually, after 2 years of treatment and maximally 3 years of treatment, you're not able to stimulate bone formation anymore with neither PTH 1 to 34 or PTH 1 to 84. We don't know the reason for this refractoriness, but it is important in a clinical light because these pain syndromes that you may see due to stimulation of bone formation will go away over time. And they are not a constant companion of PTH treatment. So what does PTH 1 to 84 do to quality of life? And we still have several studies ongoing assessing this. And so far the data are kind of incomplete, but at least in the REPLACE study, they looked at it. And here are the results. The red symbols are the PTH group and the blue symbols are placebo. And on the y-axis, you see the change in SF36 parameters. SF36 is kind of a uniform instrument to measure quality of life. And it also has its limitations. It's well known in several other diseases that you get more specific results if you produce a disease-specific questionnaire that Heide alluded to, the HPES. But at least with SF36, there was no statistically significant difference when you took all the parameters. But when they looked at single parameters of the SF36, actually there were significant improvements in physical component, summary score, body pain, general health, and vitality in the patients receiving 1 to 84. But this data, albeit fragmentary, needs to be corroborated in larger studies that are ongoing. I'll just finish the 1 to 84 study with one case where 1 to 84 really changed the quality of life for one of my patients. It was a very special patient with a magnesium problem that was a really huge issue for her in her daily life. It was a 30-year-old woman that previously had undergone chemotherapy for ovarian cancer, and that may be partly responsible for her renal damage that caused her magnesium leak. And she developed hypoparathyroidism after a total thyroidectomy. She was well regulated for 10 years on conventional treatment with active vitamin D and calcium, but then gradually developed progressive hypomagnesemia and actually had to be admitted to hospital several times with severe hypomagnesemia that could not be controlled with addition of spironolactone. She still maintained magnesium levels very low at 0.48 to 0.57. And as we all know, if you have low magnesium, your PTH, if you have residual PTH function, works less well. So she had severe problems. And she was then initially treated with 1 to 34 that we had available at that time, and there was no effect whatsoever. She had to go to hospital every once or twice a week to have magnesium infusions, which of course in the long run is a very tenuous proposal. So she got up to 2 to 3 infusions of that kind, and every time 30 millimoles per infusion. And we didn't have 1 to 84 available in Norway at that time yet. So she went to Israel and got it there and got it for a couple of months and saw miraculously that her hypomagnesemia was improved tremendously by 1 to 84. And when she came home and we actually to Norway again, and we actually could give her 1 to 84, we saw the same within a very short time, she didn't need these frequent magnesium infusions anymore. I cannot really explain why this happened, but it has been repeated several times in this patient. And now she's down to maybe needing an infusion every month. And she's actually trained herself in giving herself infusions at home, which she does very well. So she's doing much better now on a 1:84. The final part of my talk will be dealing with a future prospect, namely an injection that gives you a 24-hour coverage of PTH, and that's the TransCon drug where they have bound PTH to a carrier. And then it is bound by this green linker here that secures a gradual release of PTH from this carrier in the circulation. And with that, they can create a sustained release of PTH and a stable value over 24 hours. So here you see the levels with different doses of between 12 and 24, 24, of course, the highest level, but you see that relatively stable levels over 24 hours after one injection. And this is currently undergoing phase 3 trial, has not been approved for clinical use yet. It cannot happen, of course, until the phase 3 trial is finished and approved. They have also looked at the quality of life, and of course, in a very limited number of patients, again, preliminary results, but they see improvements in SF36 physical component summary and mental component summary as shown on the left, where the gray columns are the results obtained with the drug, and you also see here in a different way of showing it that you get improvements. But again, it's a limited material and needs to be repeated in a larger material. They have also used the HPES that Heide alluded to, and here again they see reductions equivalent to improvements with the drug. And the last issue I'll deal with is continuous PTH. We have dealt with that in Norway now for the last 10 years, I think, or even longer. And my previous co-chair, Helen, was one of the first to get this treatment. She actually instituted it more or less on herself, and she has since then been a very valuable collaborator. She instructs all the patients in Norway that we give this insulin pump, and of course, we only reserve it to very, very selected patients where we do not get to the end result and get a reasonable quality of life with either conventional or PTH injections. And this is an Omnipot where the reservoir is here shown on the arm. You inject the PTH there, and they have developed special procedures, and it goes really well on the kitchen table, no problems with infections or anything like that. And you get a readout here, and you can adjust the pump, the infusion rate of the PTH as you do with insulin, for which this pump was developed. And I think we have around 14 patients on pump in Norway, and we are very privileged because we have the health authorities have actually granted these patients also a very sophisticated calcium ISTAT measurement apparatus, so they can do calcium measurements at home whenever they want. Of course, this is a very expensive proposition, but fortunately the authorities have granted this to these patients, and it has really had tremendous impact on their quality of life. These are some of the results we've obtained. These are the same patients on conventional treatment, on PTH pen and PTH pump. And what this shows you is a visual analog score of extremity pain due to cramps. You heard in the first talk that this is a dominating, of course, I don't have to tell the patients that are listening, that this is a dominating issue when you have hyperparathyroidism, these very painful extremity cramps that can even occur at night and disturb your sleep. And what you see is that we did not really, in these patients, have much of an effect with the PTH pen. But when we gave them the PTH pump, we were actually able to achieve a significant improvement, probably because we were covering the whole 24 hours with this pump. The pump also, of course, can give you a bolus and which is very valuable if you are during the day experience low calcium levels. And what we have learned from this is that any kind of stress and any kind of infection increases the need for PTH tremendously. It's one of the biggest problems teaching the patients that it's totally harmless to increase the infusion rate, because PTH is out of the blood within few minutes. So you don't get the problems you have with increasing the dose of calcitriol. But it takes a long time for the patients to be reassured about that, because they're so used to calcitriol and the aspects associated with that. But this has really shown us how important stress and infections are, and that can really exert major problems for patients with hypoparathyroidism. So to finish off, what are the cons to PTH therapy? Yes, as already mentioned by me and other speakers, it does not fully mirror normal calcium regulation. As we don't get 24-hour coverage unless we use pumps, and this is a very laborious proposition for most patients, and most countries it's not available because it's not funded by the health authorities and or insurance companies. And the other thing that Heidi showed you is that actually PTH has a pulsatile secretion pattern, which we are not able to mimic with our current modalities. There's the risk of hypercalcemia if you overdose. It is quite small with PTH, and it's not long-standing as it is with calcitriol. As soon as you reduce your dose, you get a very quick effect on the hypercalcemia. So not nearly as a big problem as we see it with calcitriol. Hypercalceuria, as I showed you, the main effect is low calcium excretion. Of course, if you overdose tremendously, you may get hypercalceuria. And then, as mentioned in the first talk, there's increased bone remodeling that may elicit growing pains. And I was surprised by the first speaker mentioning this as a problem. Actually, this is a good sign for the patient, except for the pain, because it shows an improvement of skeletal status. And as I said, it doesn't continue. The skeleton becomes refractory to this aspect of PTH action. So it doesn't last for your life. It just lasts for a short period of time. And the pain associated is usually very minor. But I've had one patient with severe pain. And what we do there is just to discontinue PTH for 2 weeks. We also do that in osteoporosis patients. And usually when you then start your PTH, the problems are not nearly as pronounced as before. I've not had any patients giving up PTH due to skeletal pain. And it's quite expected that the bone markers will go up. This is what we want to see. We use bone markers to monitor the effect of PTH in osteoporosis, so it's not surprising. There has been an issue of osteosarcoma that mainly was the bone cancer that mainly was stemming from data obtained with PTH in rats for osteoporosis use. And we must say that it is not an issue with the doses we're using. These rats were receiving lifelong doses, and they are tenfold more sensitive to PTH. Osteosarcoma has not emerged as any kind of clinical problem with PTH in clinical use. There's a price very high, which limits the access in many countries. Some countries are not even permitting patients to get the drug. And of course, it's a daily injection with all the hassles that entails. The pros, we're supplementing the hormone that the patient is lacking. And the problems associated with that are not much different from what we see with insulin and other hormone replacement therapies in endocrinology. They're not perfect, but they're better than not giving it. You get increased, and it's easier to increase the calcium levels, especially in problematic patients, like, for example, gastric bypass patients, obesity surgery patients, where you take, or other kinds of patients with malabsorption, where the gut is not able to absorb sufficient amounts of calcium. There, this PTH treatment, and especially the insulin pump, the PTH pump treatment, is extremely beneficial. In some patients, you're not able to achieve stable calcium values just with calcitriol and calcium. You get a lower urinary calcium, as I showed you, although it's still subject to discussion, as I understand. There's improved muscular, cerebral, and sensory function. There's improved endurance and improved quality of life, albeit that we need more and stronger data in these patients, as shown by Heide in previous papers. The impact on quality of life, and also witnessed by patients today, is tremendous from this disease, and we need to optimize our treatment to really improve it as much as possible. And again, continuous infusions, we are permitted to use it. I know a lot of other countries it's just impossible to do, but it certainly is a lifesaver in very severe cases, and it permits rapid correction of calcium problems during stress and infections. And with that, thank you for your attention.
Thank you, Eric. And we continue with the patient.
Hi, my name's Ray. I'm going to try and sort of describe my journey and my experiences with using PTH in a pen. So my background is I suffer from, or did suffer from, familial hyperparathyroidism. So everybody in my family, or well, most people have calcium issues. When we have family get-togethers, we compare calcium numbers and throat scars. But I was diagnosed with benign adenoma in 1989 and had a partial parathyroidectomy, which resolved the issue nicely for about 10 years. But unfortunately, I had recurrent adenoma in my parathyroid tissue, and I had another parathyroidectomy, but which went very badly wrong. And the surgeon accidentally removed all my parathyroid tissue, so I joined the Hypopara family in 2002. For the next 10 years, I was treated with the conventional therapies we've heard so much about today. But I unfortunately suffered from the symptoms that Natalie and Tanya have described: very poor quality of life, very poor calcium control. I just wanted to stay in bed really for almost a decade. So not really a very satisfactory situation. But I had a very proactive endocrinologist, and also through the help of Liz Glenister, who we've heard from today, I enrolled in the Replace trial that Eric has just described using 1-84 PTH. And for me, it was like the lights had come back on after nearly 20 years of struggling. And I remember sitting on my sofa one day thinking, my God, I actually feel normal again. And as a consequence, my response to that drug, I was allowed to stay on the product until, as Eric mentioned, it was discontinued in 2012. And at that date, I moved on to 1-34. Albeit off label, and that's already been mentioned by the other speakers. So this photo shows my pen with them. I'll explain why. There are 2 syringes there in a moment, but I have a little bit of vitamin D and some magnesium there as well to keep me going. Next slide, please. So as Liz mentioned as well, sort of tweaking medication is quite a challenge in hypopara. And certainly going from 1-84 to 1-34 was quite a challenge as well. Mostly for the reasons that Eric described, in the sense that the half-life of the 1-34 is much shorter than 1-84. So initially, I used the pen as is, just a shot in the leg once a day. But I would be hypocalcemic on waking, and then I would have a very a high level of calcium shortly afterwards, so hypercalcemic post-injection, and then by the late afternoon I was back down to hypocalcemia again. So the solution was to actually, instead of taking one single dose, was to split the dose basically every 12 hours. So I still I'm a little hypo first thing in the morning, and by 5 o'clock I'm dropping again, but I have much better control than I did before. So Eric's already called out the pros of PTH. I mean, for me, just significant changes to what I had on calcitriol or alpha calcidol, energy, cognitive function. I'm a research scientist for a drug company, so having some idea what I'm doing day to day is very important. But it's like the lights have come on versus where I was. I have normalized urinary calcium output. I know some of the speakers have debated that today, but mine dropped into the region where it should be. My calcium is more stable, and equally, I don't take calcium carbonate or other supplements. I just rely on my diet. So a lot of pros from my point of view. In terms of cons, you have to refrigerate the 1-34. It's quite fragile. So when I fly anywhere, I've been asked why I'm bringing my refrigerated sandwich box onto the plane, but it's a bit more important than that. As Eric also alluded to, the calcium fluctuations are faster than alpha calcitriol, which is good in some ways, but equally things move faster, which can be a challenge as well. My experience is that with 1-34, for the reasons that I and Eric have mentioned, is I'm not as stable as I was on full-length PTH, but I think in the UK, for the time being, this is probably as good as it gets. And occasionally, I sometimes make a mess of the injection and I have a bruise or a hematoma, but very, very rarely. But to me, I just can't overestimate or overstate the positive impact on my life that hormone replacement therapy has had. So I'll try and answer any questions at the end. Well, I'll do the first poll then. Did you know about hormone replacement therapy? So did you know about hormone replacement therapy. So number 1 for yes, number 2 for no. Okay, so 82% of people know about replacement therapy, which doesn't surprise me. So yeah, so I think that's me done. I'll hand over at this point. Thank you.
Okay, thank you, Ray. I'm Barbara from South Germany, and please, the first slide. Well, I have had hypopara for 13 years now because of parathyroid surgery. After 11 years of conventional therapy with calcium and calcitriol, I was switched to Natpar in November of 2019. Ever since I became hypopara, my calcium excretion has always been high, and you can also see calcium depositions in my kidneys. My calcium levels were also unstable. I was often hypocalcemic and I had tetanic symptoms. Together with my doctor, I decided to try out Natpar. Natpar has been available on prescription for patients with hypoparathyroidism since it was approved in Germany in 2017. I still checked with my health insurance company if they would cover Natpar, as it is very expensive. Depending on the indication, it is usually prescribed by endocrinologists, like in my case, or nephrologists, occasionally also by specialists, nuclear medicine or internal medicine. Pardon. When I switched to Natpar, a patient coach from Takeda looked after me. With her help, I learned how to handle the pen, how to change the cartridges, and how to do the ejections. Please, next slide. Now, so this is how the pen looks. The needle is on the left side, under the cap. You then have the cartridge, and on the right, you can see a mechanism that twists and also a counter that tells you how many doses you have administered. The cartridge lasts for 2 weeks. You usually get prescriptions for 3 or 4 months, so you have a certain amount at home that lasts for a while. Next slide, please. I had a lot of questions and was also very afraid to give myself injections. For me, the support and training were important to avoid mistakes and to gain confidence. We started with 50 micrograms of Natpar, then that I injected every morning. When you switched from conventional treatment to PTH, you need to be monitored closely by your endocrinologist or your family doctor because you need frequent blood tests. In my case, I took around 12 weeks to phase in PTH. I was able to reduce my calcium supplements by half and phase out calcitriol altogether. After 1 year, the dose was increased to 75 micrograms because I started to need more calcium. There seems to be a kind of habitation effect which happens often, apparently. After we raised the dose, my body needed some time to adapt. It wasn't easy. Currently, I take a small amount of calcium every day in the evening. Because the PTH peaks at noon and drops towards the evening. You saw it. My calcium level is lowest in the morning, which sometimes doesn't feel good. I do not take any calcitriol. but take 1,000 international units of vitamin D3 every day. That is my own personal maximum. I cannot tolerate more than 1,000. Generally, my calcium levels are more stable and all relevant blood values for hypopara have improved. I still have fluctuations depending on my diet, the temperature, physical activity, stress, etc. Last year, I had a problem after dental surgery. So despite NADPAR and despite calcium supplementation, the calcium metabolism was completely off balance after my surgery. It took weeks for it all to finally get back to normal again. Nobody could explain to me what had happened. I think more research should be done on the interactions between our calcium metabolism under NADPAR and other drugs, as well as anesthesia. Overall, I have got used to the injections every morning. If I want to travel for a few days, I need to plan well ahead. How do I transport the pen and maybe also beverage while keeping it cool? For how long will I be traveling? Is there a fridge at my destination? And so on. So far, I have avoided major travel and I have not made a plane trip yet. Maybe it will be in the future. That's it. Thank you.
So thank you, Barbara. We have a poll for your session now. So the poll is hormone replacement therapy available in your country? The first answer is yes. The second answer is no. And the third answer is I don't know. Once again, the question is hormone replacement available in your country? The first question is yes. The first answer is yes. The second answer is no. And the third answer is I don't know. Could we have the results, please? Well, I don't know, the 46%, that's great. So 46% say that the hormone replacement is available in your country. It will be interesting for us to know what the patients that have answered, what are the countries represented here and the percentage. 24% answered no and 30% answered I don't know. So this is interesting. So could we have the next slide, please? So we have just seen the two different types of hormone replacement treatments using a pen, one with the PTH 134 and one with the PTH 184. We are now going to talk, I know Eric Fink already mentioned it, about the infusion pump. So how does it work? So we have two examples. One will be presented by Helen, and I will present the other one. So I've already presented myself. However, what I have not said is that after the 4 weeks I spent in hospital and that I was symptomatic for a very long time, the standard treatment just didn't work really well on me. And this is why having a pump made a big difference for me, but I didn't get it before 2018, which means I did live 10 years very symptomatic. In Ray's part, he explained to you how to use the PTH 134 with a pen. In my case, the pump is something that I need to keep on myself at all times. This is 24 hours a day, 7 days a week. And I am only allowed to remove it. Oh, sorry, can you pass on to the next slide? And I am only allowed to remove it 1 hour a day. So that's the maximum I can remove it. The pump is managed by a device that I need to fill every 3 days. And it is then placed in an external belt or in a pocket. So on the image there, I do not have the pointer, but you see the belt and you can see the device. So you can either put it in the belt like at night or in a pocket, a special pocket during the day. And I also need to insert a cannula manually into my body, which you can see on the picture there, the person that has it on the body. And I do that with a device that looks very much like a big stapler. I can insert that cannula in my thighs. I can insert it around my stomach. I can insert it around my waist, on my buttocks. I wouldn't advise on the arms because I have a catheter that is attached to the pump in itself, and it wouldn't be very practical when lifting up my arms. Can we pass on to the next slide, please? So the pump I use is the iJet. It is a small micro infusion pump, and it delivers the liquid medicine subcutaneously through a small catheter under the skin that I just showed to you in the previous slide. In my case, a small dose is injected every 3 minutes into my body, and the dosage required depends on the person. But for those that I know, it ranges from 0.014 to 0.021. I don't know if it's milliliters, but that I know is what I program on my pump per 24 hours. And the preparation is done for 4 days. So every 3 days I make the change, but the preparation is for 4 days in case there is a problem and that you can't change it on time. I inject 4 pen pumps into the syringe, plus I add 1.6 milliliters of water for injections in that syringe. In France, the infusion pump method is experimental, and we are very few to have it. And it is definitely not something that is yet readily available, and it is not reimbursed by our healthcare system, as they have not approved it as being necessary, let's say. It is, however, a very interesting treatment, and we will be looking in more details why later. It's your turn, Helen. Next slide, please.
Thank you, Natalie. I would like to add that for those who don't know me, I'm Helen Dahl-Hansen. I'm the head of the patient organization Hypopara Norway, the former Nordic Hypopara organization, which was founded in 2005. And I would like to talk a bit about the Omnipot that Professor Fink Eriksen mentioned, that he uses for fragile hypopara patients in Norway. I would also like to add that our members here in Norway are very happy to have such a great international professor on our disease. The Omnipot, when using the Omnipot, the system communicates directly wirelessly with a manager device. The pod you can see on the upper arm of the person in the picture. The manager device is held in her hand. The device is set on an individual base rate, which is individual for each person. The pod has a flexible cannula that inserts automatically by using the manager device. It is possible to leave the device at home when going for a short trip. Next slide, please. Thank you. The pod is filled from a syringe with a short needle with a solution of PTH and saline, which you can see in this picture. The syringe with a needle is included in every pod package. On this picture, you see the pod on the abdomen. We use BD microfine syringes, 0.5 milliliter, to draw out the correct amount of PTH directly from the pen. And we use the syringe following the pod to draw out the saline from the saline plastic ampoules. The PTH is then inserted into the saline using the needle in the pod package. The solution is mixed slowly from side to side. It is possible to go for a short swim or shower with the pod on. You may give a boost dose if needed. You also see how we prepare on this slide. We use 0.13 milliliter of PTH 184 with a strength of 100 microgram and 1.25 milliliter of saline water for injections. We are happy to have this pump reimbursed for our disease here in Norway, thanks to Professor Pth Eriksen. But the legislation may vary depending on country. So the next slide, Natalie, is for you.
Yeah. So we mentioned previously why we thought it might be interesting to mention the infusion pump during this presentation, and we tried to create a chart that would represent the fluctuations of calcium depending on the type of way you are using the hormone. So the yellow line represents the PTH 134 that was presented to you by Ray. The blue line represents the PTH 184 with a pen use that was presented to you by Barbara. And the green line, we try to represent how it works with the infusion pump. As you can notice, the yellow line, and as Ray mentioned, it represents his 2 doses per day, his 2 half doses he injects during the day. He is going to very quickly have a rise in his calcium levels after the injection. But as PTH 134 for Steo has a 3-hour half-life, these levels are going to drop quite quickly within his bloodstream, and he needs to do this second injection later on at a 12 or 10-hour interval. I know some people that do them 3 times a day to be able to get his calcium levels to come back up and not drop drastically at the end of the day. Otherwise, he'd be in a hypercalcemia situation that wouldn't be very pleasant at all. In the case of Natpar, which has a 12-hour half-life, when Barbara injects her hormone with the pen, she is going to have a quick rise of the hormone level, but as you can see, it is going to decrease on a much longer period as it has this 12-hour half-life. In the case of an infusion pump, as we have hormone injected into our body regularly, we are going to be much stable throughout the day. And this is why it is important to present this method of delivering the hormone replacement therapy. The thing is all the same that fluctuations will affect us very quickly, and as it's not acting as our actual parathyroid glands, if there is an extra demand for PTH, at least with the iJet, I am not getting that extra dosage that I may need. It's not the same for Helen. Next slide, please.
Thank you. The infusion pump compared to standard treatments as reported by patients. They report improved quality of life, improved brain fog, improved strength in the body, easier to perform daily tasks. They require less time to recover and improve the quality of life. They have less cramping, less bone pain and muscle pains, and also less calcifications. Improved kidney function because of less calcification. Disadvantage would be need to change pump every third day, but for others, I mean, they inject every day or twice a day or take calcitriol 3 or 4 times a day. So the device is always on us. Mini fridge and all medical equipment when traveling we need. Patients report no major memory improvement, though they have less brain fog. In the iJet that Natalie uses, extra concentration and physical activity not compensated as booster dose not available on her pump. It is not waterproof as in the Omnipot. The device is quite big and need to plan clothing accordingly. Next slide, please. Infusion pump compared to daily PTH injections as reported by patients. In summary, as you did see from the simulation slide from Natalie, the problem in Hypopara is that the calcium ion fluctuate too much. In a healthy person, the calcium in blood do not fluctuate at all. With the pump, the calcium fluctuation is less, and you are able to wake up in the morning with not having a low calcium value in the blood or throughout the day. This gives a better quality of life, less hospitalizations, and the feeling of security. And we do not have to carry the pen with us, and we are more stable and with no extra physical or cognitive activity. And as Professor Fink Eriksen mentioned, infections are no good for us. So then we need to give a booster dose, extra calcium, or even get the pumper on a higher rate. We need to change pump every third day. The device is always on us. Yeah, and it was what I mentioned before. The next slide, please. Yeah, and poll 3. Do you think the infusion pump should be the future of hormone replacement therapy rather than pens and syringes? 1, yes. 2, no. 3, difficult to say. So I repeat poll 3. Do you think the infusion pump should be the future of hormone replacement therapy rather than pens or syringes? 1, yes. 2, no. 3, difficult to say. May I have the results, please? That's great. 58% says yes, 0% says no, and difficult to say around 42%. But that is a great answer. 58% says yes. Thank you so much. And the next slide, please. Yes, Natalie and I would like to thank the Norwegian patients that kindly provided us with their input on using the pump. Thank you so much.
Thank you very much to all of you. So we can take questions now. I would, if possible, like to filter out the ones that concern hormone replacement therapy and then leave the other ones for later. I already answered one. There was one in German. It was, do you put any preservatives into your pump? And I said, no, you don't. Helen, you just dilute the NADPA in saline. And yeah. Natalie, you just dilute the Forsteo in regular water for injection. Yeah, okay. So that one has been answered. Okay, maybe I can read the first one by Ernst. Does anyone know whether the replacement therapy with PTH is approved in Austria, and whether with injection or with the insulin pump? So who knows if it's approved in Austria?
So perhaps I can answer, because it's approved in Austria as a regular 1:84, but it has to be, it's important to, it has to be like officially applied. Okay, perhaps I do the next one. Here's a question: is hormone replacement therapy available in the UK? So this is the next question. Who wants to answer this? Who knows this?
Liz, maybe? Or Ray?
Right.
I mean, I was going to ask Liz to answer. I mean, I think I use 1:34 off label. I think 1:84 is approved, but I think NICE are greatly restricting access to it. I think it's only in exceptional cases. I think Liz knows a few people, but maybe she could comment.
Perhaps there's the question we can ask to Eric, because when we have him here, and it's good to ask. There's a question on calcitriol. If you change from the original to the generic forms, do you see in your patients differences that you have to increase the dose, double the dose, for example? Eric, do you see any?
I've not had to do that, so I don't know.
Okay.
We still have calcitriol available, so we have not had problems with that. But generally, with these simple molecules, I would not expect the drug to be different. But of course, if there are additives in the tablets that may affect absorption, that could be a problem. But I have not personally any experience with that.
So Sylvia wants to know, when is TransCon approximately expected to be available for patients?
Yeah, I can answer that. It's still undergoing phase 3, and it's impossible to give exact, but at least the phase 3 is still ongoing, and then it takes another year from when the phase 3 is finished. I don't know the exact termination of the phase 3 trial, so at least 2 years from now, maybe more.
So there's a question with the continuous pump treatment. Is there a time frame before it stops working? She was on conventional therapy and stopped working with the forteopen, and now she's on and that stopped work, currently on a pump. But if there's a time frame how long this will work, is it to be expected that there's something like a reduced effect of the pump? What are your experiences with different?
So I haven't noticed a reduced efficiency of the pump with Forsteo over the past 4 years. Helen has had it for much longer, so she will be able to.
No, I have not seen that either on myself or others.
No, we are not seeing it with any patients in my experience. I just mentioned that the effect of PTH on calcium metabolism and renal handling of calcium seems to stay there and be constant, but the skeleton becomes refractory after 2 to 3 years. It doesn't continue to stimulate the skeleton.
So another question: how big is this cannula that you have on your pump?
For which one? Because it depends. Mine, the cannula is really small, but the device is really big. For Helen, her cannula is bigger, but her device is not on her.
Yeah, it's not with me.
So,
but the needle is, plastic needle, and is inserted by the device itself. So it's very, very fast, very, very small, and it doesn't hurt. So it's great.
Very important questions. I have another question, perhaps, to all of you. Given the improvements experienced by those receiving hormone replacement therapy in quality of life, fatigue, and cognition, do you foresee this becoming widely available it feels that expensive health authorities are more likely to push conventional medications that don't necessarily impact these symptoms. So what are your impressions on this?
I mean, my understanding is that 1 to 34 is about to become generic or already may be generic. Maybe Eric knows. So I suspect cost may be less of an issue there, but I guess NADPAR will continue to be pricey for some time yet.
There are several generic compounds of 1 to 34, yes, already available on the market. We have it in Norway also, and many other countries. And 184 will get generic competition also after a while. But it's still, of course, a very expensive treatment. Just a side remark: when you use the pump, your general consumption of PTH goes down compared to pen.
Okay.
How long does a cartridge work for you, Helen, of NADPAR? It's more than 2 weeks, isn't it?
Yeah, I usually change the cartridge after 2 weeks.
Okay.
Because I'm afraid it doesn't work, shouldn't. So I change. Yeah.
And in the case of the Forsteo, I use 2 pens per month, but most people only need 1. And Forsteo is reimbursed currently in France. It's the pump that is not reimbursed, and that's what's the most expensive.
We have a question.
I would like to add that we don't, in the Omnipot, we don't use more than the same price as for one person who uses 1 injection a day. So that's great too. Okay. So we are not more expensive.
So here's a question that on children. Can children use the PTH pump?
I can answer.
Yes, we have several. Sorry, we have several children in the UK on pumps,
and in France
using 134.
One of the first studies on PTH pumps was in children from the USA, so it's been used. Yeah.
So another question from Sylvia: what happens if one has to get off the PTH therapy? Because in the US, NADPAR, as you know, was recalled. So could you maybe explain what then happens to patients to return to conventional therapy?
Maybe I can take that one, because when I had to come off PTH at the end of the Replace trial and go back onto calcitriol, and it was extremely difficult. It was, I was shoveling in huge doses of calcitriol, and my calcium was about 1.4 for about a month. So coming on and coming off PTH is extremely difficult. That would be my experience, but it'd be good to hear others' views as well.
I would recommend that, if possible, change to 1 to 34 if 184 is discontinued, like the States. I don't know how many did it, but I know some did in the United States. I absolutely agree. To go from PTH and then back to conventional would be a hard bargain.
Yeah. It was, but equally, Eric, I went from 1 to 84 to 1 to 34 when it was discontinued, and that was difficult trying to get the right dose, but it wasn't as bad as using calcitriol.
No.
There's another important question. There's now generic forms for TEO, so teriparatide is generic. Did anybody of the pump or of the application has experience if this makes a difference in treatment, or is it really similar? Is another question.
I can answer that one because they've just wanted me to go into the generic form of Forsteo, and I am not ready to try it because I believe I'm going to have to ask my physician to make sure that I have to continue with the original one, because otherwise it might affect my dosage, and I don't want to have to do the blood test every 2 days again.
I can add also that virtually all our pump patients, they've tried both 134 for a period and 1 to 84, and then Helen may add to this, and they all unanimously more or less say that they do better on 1 to 84 in the pump. So it's not just a matter of half-life. There are some other aspects of the hormone that plays a role. Could you add something, Helen?
I just agree. There must be more to it. In the many years ago, you said the 134 was the active hormone, and the tail was not important, but there must be something in the tail.
Okay, I think we have now finished our session. Thank you very much for this great talks and for this great discussion and this input. And now we give on time this time. This is really, thank you everybody that they all were on time. We go back to Andrea.